Okay, it's 7 o'clock. I'd like to call the EMS Commission meeting to order. If we could do a roll call.
Certainly. Janelle Rice. Here. Connie Hilla.
Here.
James Roberts.
Here.
Kate Cronin.
Present.
Derek Johnson.
Here.
Greg Miller. Mike Durst.
Here.
Terry Schnapp.
Here.
Sue Loganville.
Here.
Chief Anderson.
Here.
We have a quorum. Public comment, there is no public comment.
Get your signs.
Everybody get a chance to look at the minutes from November of last year? Any comments? If not, I'd support a motion to approve.
I make a motion to approve the minutes from November.
Is there a second?
Second.
All in
We
favor?
have one adjustment from the November that we caught up on. I think we had some conversation around some numbers that were some subtotals that were different.
That's reflected in the minutes.
Yeah, so there's a note in there that it was wrong. Yes, I fixed the math. It should be good this month.
Thank you.
Okay, were everybody in favor? I kind of lost track there.
Aye.
Aye. Okay, any opposed? Minutes are approved. We have a presentation. Do you want to do this? Sure.
Set up the table and pass the microphone over. So we've been talking for the last couple of months about our partnership with UW clinics, and we've been talking for years about how we're going to assist students do that paramedic outreach programs in our dementia community. Dr. Shaw approached us a while ago.
Probably.
And it just kind of, it was a slow-moving train, but we got some forward momentum on them, and I know I've explained the program a couple times to my understanding of it. And I know Derek had some questions, so I asked him to come in and talk to this. So this is our EMS Commission, this is our governing board from our communities, and to kind of tell them what we're getting involved in with you and how we're going to benefit the community. Thank you.
Excellent. Well, thank you for giving me a little bit of time to chat. I thought what I'd first do is maybe give a little bit of my background so you know who I am, and then kind of move into some of the rationale for this and a little bit of the details on the program. So I'm a professor at UW in the School of Medicine and a researcher there. I'm also one of the ED docs at UW Health. Technically, it's actually a project with UW and not UW Health, but that's okay. It's close enough. They're interrelated. The relevant background here.
I'm just a farmer.
Emergency department.
Sorry, emergency physician, ER doc.
Okay. ER, okay. Okay.
The relevant piece also to this is that before I came to UW about 4 years ago, I spent the better part of 15 years running EMS systems as the medical director and running the county and the city EMS system, et cetera. And a lot of the work that I did was really about bringing together and thinking about how we can use EMS in more of a community health and a public health role rather than purely the emergency response. We now have a fancy term for it. We call it community EMS or community paramedicine. I did not patent it or copyright it, and so I don't get to make money on it. But it now encompasses everything that we pushed for really for over the last 20 years or so, which, believe it or not, 20 years ago, no one, including EMS, had any interest in this, which is very different than it is today. As we've kind of thought about the various roles that EMS could play in terms of improving the community health, one of the areas that has become important kind of at the national level as we talk about this is how we can help folks with dementia. We know the population of folks with dementia in the community is growing very rapidly. We know that they struggle with memory, behavioral issues. They're tough for us in EMS to take care of because of the things around the disease. On the ER side, they're really tough for us to take care of because it's kind of a horrible place for someone with dementia. They don't recognize the place. It's loud, it's noisy, there are people they don't know. We do all sorts of annoying things like stick needles into them. And so then the question became, and what we've been working on for the last couple of years has been, how can we use community EMS to support folks with dementia in the community so they don't need to call 911, so they don't need to go to the hospital, and so that they and their family members can just have better lives. We did a project for a couple of years where we interviewed all sorts of people in the community, including a number of paramedics at Fitch-Rona and leaders at Fitch-Rona, folks with caregivers of people with dementia, geriatricians, EMS docs, ED docs. And through that work, we sat down and pulled together a model of care that could potentially help support folks with dementia in the community. We pulled something off the shelf that's been validated in other areas called REACH. It's a coaching support program to help teach caregivers of people with dementia how to better manage their loved ones and to work with healthcare systems and stuff like that. But then as we've been developing this, we set it up so that community paramedics could actually deliver the intervention. It's a coaching and educational intervention, so it's not rocket science, but it's an important piece, particularly if someone who has a lot of capital, so to speak, in the community, as a paramedic does, or a firefighter does, or a police officer does, is delivering and working with them, they can actually, we feel, can make a fair amount of headway with these folks. And so as we were looking through the UW health system in terms of what clinics could we work with to basically beta test this model that's actually been rolled out by social workers and nurses in some other parts of the country, we came upon there was interest from the Belleville Family Medicine Clinic that they really were very interested in working with this. They have a fairly high dementia population that they wanted to try to be innovative with. Given the conversations I've had with Chief Anderson and Dostalek over the years around this, and given the number of Fitch-Rona folks that participated in this, and given that Belleville is part of the ALS response for Fitch-Rona, we turned to Fitch-Rona and asked if they would be interested in participating. And it worked out. And so what this means really for Fitch-Rona is a couple pieces. First is that we got funding from the National Institutes for Health to contract with Fitch-Rona to provide the community paramedic. We're training the community paramedic on things around dementia, on this REACH program, on motivational interviewing, and on working with the Belleville Clinic. And we're going to essentially test this within this model where we'll have about 15 patients from the Belleville Clinic who will give consent along with their caregivers, and then we will deliver the REACH intervention as it's been adapted so that the community paramedic can give it. It'll go over a year or so for the full intervention. And we're going to measure a handful of things. I mean, this is truly a beta test type thing. This is not a randomized trial where people will get it and some people won't get it and things like that. We just want to see, can we do it? Can we use paramedics to do it? Will it work? One of the kind of other innovative pieces here, which the REACH folks, which is run out of Georgia, they haven't had a lot of luck working with health systems. A lot of times they're just kind of set up as freestanding organizations and community nonprofits delivering it. And so one of the innovative things here is actually integrating it in with the Belleville Family Medicine Clinic and actually communicating bi-directionally with them, with Sugar River Senior Center, who we've talked to extensively, to really bring community resources, medical resources, and education for the caregiver to really support these folks. If this works, the goal is to actually truly do this as a trial where we would give some people the intervention and other people not, to see if it actually reduces ER visits, see if it helps with preventing burnout in caregivers, which is a huge problem, if it helps with better communication with the clinic and better knowledge and stuff like that. There's a whole list of things we're going to be evaluating that I'm not going to bore you with, but the point of this is really kind of an implementation. Can we do it? Can paramedics do it? I know the answer. We totally can do it. EMS can totally do this, but it's helpful to see what works and what doesn't work and how we can make it better and how's our training that we've come up with and stuff like that. So I'm going to stop at that point and then maybe just open up for questions if that's okay with you.
I just have a question. You said that there's about 15 patients from the clinic. Are these patients that are identified as frequent users or?
So we're going to do 15 patients. They have way more than 15, but for budget and other reasons because we only really need 15 to get a sense of what we want to answer. They're not necessarily frequent users, but they are individuals who have dementia, have a caregiver in the community that the clinic has identified as people that may be able to benefit from this type of program.
But if you're trying to determine that the frequency of using, the emergency room, it wouldn't be beneficial, kind of where you were going, like who are the most users and see if that's going to decrease.
You're right to some extent. So I think that would actually be the next step. This first step, what we want to make sure is does this program work when we're using a community paramedic to deliver it? They've never had a paramedic deliver it before. We also want to look at timing, and from the caregiver side, does it work for them within this model? So you're right. So if we can show, hey, you know what, this is working, we've tweaked this model so that patients are happy, the paramedic's happy, we look at how long it takes to do all of this, and it works out. Then we would move to exactly that question is, does it change, and particularly among people that use it a lot? We're just not quite at that point yet, given how new this is. We don't want to jump in with both feet in the deep end and then realize we can't swim. Sir?
Of the 15 people you have, and you said there's more than that, so I'm just gonna say there's 30 just to make it. And do they have them rated like 1 to 30, so you kind of start at 1 and go every other one to get to 30? So an example is 1's the worst, and it doesn't work with that, and you go all the way down to 30 and it works just great, but somewhere around 10 is where you have them set up. Is anything like that being done, so you don't just, is that what you're kind of doing with it?
So when we did these interviews with the geriatricians, the docs, the paramedics, what we learned from that, and from the caregivers of people with dementia, is that there's a sweet spot in which a program like this could work. And what we found out is someone who has super severe dementia, where they can't communicate at all, can't get out of bed, can't do anything, basically needs almost a nursing home level care, would actually be very poor for this type of program. And so what we've actually done is, based on kind of the national experience that the REACH program developers had, and this has been validated through studies previously, and based on all the interviews we did probably 50 or 60 interviews, we've identified the people that we think that's the sweet spot that could really benefit from this, and those are the ones we're targeting right now. If that works, where we say, hey, we know we can actually deliver the program well, then we're going to want to broaden it out and try to figure out, does this work for everyone, or is there a subgroup that this works for?
Where's your line? Okay.
Absolutely. No, you guys, I love where you're going. One thing I've learned in my 20-odd years as a faculty member and a researcher, and I mean, I've had a reasonable amount of success with research. I love jumping to the really critical question, but unfortunately neither the federal government will not fund it, but even more than that, it's not necessarily safe. You don't want to do a project that gets into your question or your question if we can't show the foundational piece is good, because it's just not appropriate to put people at risk, so to speak.
So if NIH is funding it, it must be somewhere else. Someone else is using this or has success somewhere.
Yeah, so this has been used, it's actually been funded, the development was actually funded by the NIH years ago, and it's being done by social workers and other groups. There's a group up in Appleton that's actually doing this. It's the only other group in Wisconsin. But no one's ever had community paramedics do it, and they've been relatively unsuccessful working with health systems directly. So that's probably our two real innovations here is integrating with the docs and the clinics carefully, as well as integrating with the community paramedics. The other reason, and so when I was in upstate New York, I was actually the medical director of a rural county towards the tail end of my time there, and I always felt pretty strongly that the community paramedicine model would work best in rural counties, because you often don't have as much in the way of resources, home health, home nursing, and stuff like that. And that's why Belleville was kind of an interesting option for us, because that clinic, I don't know if you guys are familiar with it, but they actually have a lot of resources for a clinic. They have the x-rays there, they have lab there. I feel like the docs I've talked to there are pretty passionate and pretty committed to that clinic and the community around there. And so the hope we have by working with that type of group and a clinic that's got those added resources is we can really help keep them in their homes and where they want to be.
And the paramedics have the bandwidth to take on this program?
So there's some additional training that's, right now we've got one, we talked a little bit about last month, we kind of found our ideal candidate. And, so Meg has actually been doing some additional training. One of the challenges we do face is the use of that word community paramedic as it tries to become, we've been talking as a group about this for years. Years. It finally is now a official licensure at the state level.
Almost.
Yeah, almost, sort of, but there's no substance to it. So we, have to kind of tread lightly about calling somebody something because then it requires licensure, which then there's an educational component which has yet to be defined. Yes, so she's been doing some additional training with that. And as long as the kind of direction we've gotten from the Department of Health, which oversees all of our licensure, is as long as we are not stepping outside of our scope of practice, which is very well defined and is as part of this program will not occur, right? As long as they're doing what a paramedic with a license out of school can do, we can do what we want to do. Sort of.
And the beauty on this one is that they are only really educating and talking. I mean, they're not coming in with any equipment. They're not using any of their IV skills. They're not using drugs. They're not using anything. And I actually sat on the board that made those revisions to the code, which hopefully we'll be going through in the next couple of months. But it's a slow evolution as this space opens up for EMS to be involved in. But I think it's going to make a huge difference as we start looking towards community health more broadly than just purely responding to emergencies.
Sounds exciting.
So it seems to me that this is a complex illness and that we've got a couple of moving parts in this particular program. For the benefit of the people that may be just tuning in at home, can you give us like a little bit of a role play of how that might look so they have a sense of where we fit into
Absolutely.
that? Thank you.
Absolutely. So the way it'll work is that the docs in the clinic will identify people. They'll actually talk to the patients, or their caregivers more likely, but both the person with dementia as well as their caregiver, whether it's a husband, wife, kid, whatever. If they're interested, we will get informed consent from them, and they'll join the study. And then what will happen is that there'll be two things kind of in parallel going on. The intervention, this REACH intervention that is, it consists of roughly monthly home visits for coaching and education around everything from what is dementia, what do you experience, how to deal with disruptive behaviors, how to prepare, whether it's things like goals of care, financially, other components. There's an entire book that's about this thick that gets provided to the caregiver. So it's roughly monthly home visits as well as a number of phone calls, as well as just check-ins where, if give an example, there'll be times when caregivers will get burnt out. They'll just get frustrated. It'll get hard. They'll miss their loved one who's not, the person they remember when they got married to them 50 years ago. They'll be there to have those phone conversations and just, help coach them through that, as well as coaching them through how do you access resources in the community. Interesting story. So Meg, the community paramedic, actually took care of her grandmother for probably about 10 years who had dementia. She didn't even know about the Sugar River Senior Center, which actually had a different name back then, even though for 10 years she took care of her grandmother with dementia in Belleville. Which, yeah, you said, wow, but that was actually our response when we were interviewing her. We're kind of like, wow, if someone who is medically knowledgeable, who also is from this community and is taking care of this and doesn't know about the resources here, just coaching them about how to find the resources is a huge piece of what we want to do. Mm-hmm. So this will happen over that time period, and the goal at the end of it is that they learn to fish, so to speak. We don't give them fish; they learn to fish. So that the family members will be that much more skilled at helping take care of their loved one and take care of their family issues, really for the rest of that individual's life. Around that, we're going to do kind of the research side. We're going to do conversations with the staff people, the docs, we're going to do surveys of the people participating, the caregiver primarily, not really the person with dementia, to really see how things are going. And some of it's going to be as simple as, how is this program working for you? Some of it's going to be like, okay, Meg, how long did it take you to prepare for the visit? How long did you spend on the visit? Because one of the things is, you can imagine, if you're operationalizing this long term, you want to know, for every person we take care of, how many hours per week am I going to need to have staff spend behind that? And so that researchy evaluation piece will go on in parallel to the program actually being delivered. But the program delivery is really going to have fidelity with what's delivered in Appleton, what the folks in Georgia who distribute, manage this type of intervention, what they have defined as the standards that we have to meet. And to the extent of the standards, they get the training, they also get tested by the folks in Georgia to make sure they're delivering the training. So I think it's next Friday, Meg's getting tested by the folks in Georgia to make sure she can actually coach well and she can talk to a simulated patient well and stuff like that.
How long is your testing time?
So the program runs about a year. And to do 15 people, we're rolling them out slowly. So we're hoping that in about 18 months from now, we'll have a decent sense of what it looks like. If things are going well and Meg and there's one paramedic that works for us directly that's kind of a consulting paramedic. She's retired, actually. If they all say, hey, this is all working well, we may try pushing a little faster. If we find that there are hiccups, and I tend to be of the attitude of sometimes you just have to go and start doing, and then you fix it along the way. If we find hiccups, then it may take a little bit longer. But I actually think, given the experience with this program nationally, I think it's going to work well. I also think it's going to work well because I have confidence in our paramedics. I have confidence that in the training that we're providing them. And so I think this is actually going to work pretty well, and hopefully we'll be able to go on to the second phase, the questions you brought up and you brought up, to be able to really answer the bigger questions and try to prove this will work so others will hopefully pick it up.
Does this curriculum also include anything around recognizing when it's reached its limitation in so much as the caregiver at home is no longer able to manage?
If I remember correctly, it has a lot of materials on when to turn for help and when you're running into trouble. If you're asking the question, does it talk about when is it time to go into a nursing home? I don't think it's explicitly that way, but I have to be honest with you, I have not gone through the training. I'd have to ask one of my staff people whether they have. But I think what it does, it tries to prep for the future needs of having to look at greater supports and look at alternate needs.
And so would the community paramedic make a recommendation possibly to the person's doctor saying, like, from what I've observed, I think there may be further intervention that needs to happen?
So yeah, that's exactly the communication that we've built between the clinic and the community paramedic, is that the paramedic will be communicating to the doc saying, here's what I'm seeing and here's what I'm worried about. So then the doc, when the patient comes in for a visit, can say, hey, let's talk about this stuff. Because so often, and I even see this in the emergency department, I'll be there and I'll talk to a patient, and then the family member will come in and say, oh, it's completely different at home. You're totally missing what's going on here. And that's where the clinic is very excited, because they're hoping to get a better sense of what's going on at home so that they can better care for the patients.
I know this is not a perfect environment by any stretch of the imagination, but one of the other challenges that I see is when this is someone that you love, you feel like you must find a way to take care of them, even when you don't have the skills to do that. And so just having some mechanism to offer that normally this is a skill set that's delivered by a professional, so that the family can understand that maybe we can't give this person everything that is needed in that case, because I think that they're going to put pressure on themselves and potentially burn themselves out a little bit faster, thinking that this is someone they love and they just need to find a way to do it.
And I think, your comment is very astute, because I think that's something that happens with many diseases, whether it's cancer or dementia or whatever. And I think one of the things I really like about this REACH program is the fact that it's not purely medically focused. It's so kind of psychosocial, medical, whatever the patient needs, whatever the caregiver needs, you go meet them where they are. And I think that's very much going to be one of the goals we hope to see out of this, which is why one of the things we're measuring is actually there's a burnout survey for caregivers of people with dementia. And that's one of the ones we're actually going to be administering about every 3 months to see how they're doing. And when we get to the point where we can actually test this against, kind of what we call usual care, basically doing nothing more than we usually do, we're hoping to see that it would actually significantly decrease the burnout and the burdens that the caregivers and family members feel.
Say Meg has, when she goes for the in-home visit, does she spend an hour there, 3 hours there? What is the time? And then, how much paperwork does she have to do to qualify what she did? 'Cause I figure if she spends an hour there, she probably has to spend an hour and a half doing paperwork or something. Is that about right, or?
No, not really. So according to the REACH folks, the visits are about an hour or so. You can't go much longer because otherwise people will fatigue. I mean, heck, if I had to have an hour visit, I'd get tired. The paperwork as we've developed it on our side is moderate. I think we're anticipating it maybe about a half an hour or so, but some of it's because this is a research study, and so we're doing a little bit more paperwork than if we said, hey, we're just going to do this because we're going to do this. But that's one of the things we want to figure out and we want to minimize. I mean, as a physician, I'm very cognizant of paperwork. As a former EMS medical director, I'm super cognizant of paperwork. But also, if we're going to tell the docs and the people in the clinic what really is going on, we want to make sure we provide enough information and enough of it's documented. The nice part about this is we're not submitting bills to insurance or anything like that, so we don't have to try to match their rules or whatever hoops they try to create to provide payment. So it's one of the things we're going to figure out, and one of the things we're going to keep working on.
Is it going to be paper or a laptop or?
So it is a combination of some things on paper. The majority of stuff will ultimately be via computer. The REACH folks nationally have essentially an electronic system that is HIPAA compliant, et cetera, that manages these visits and collects kind of the key information. And so that's the one that will be used ultimately. But it's all cloud-based.
Is there a link into the medical record for the patient?
Yeah, so that's one of the pieces we're working on. We have a semi-solution that I'm hoping to make better over time, but we have one that's going to allow the clinic to get a written report of what happened that then the docs and nurses at Belleville can decide if they want to incorporate it, or they may say, okay, thank you for that information, but I don't want to drop it into the record. And honestly, I feel most comfortable doing that because I really think it's the docs and nurses at the clinic that should decide what they think of that information and how they want to stick it into the record.
Any other questions?
So Meg's ready for this?
I think so.
Yeah.
We'll see how she does next Friday when she goes through her test.
Pretty sure said that she brings that experience in this role, the medical role. She certainly has personal experience to understand what to look for from the caregiver's perspective and burnout and all of those things that have been part of her life journey. So
When I interviewed her, I was very, very impressed. It was funny. Jeff called me one day and it's like, I found the perfect paramedic for this program. And I was super impressed when I interviewed her, and I think she's going to be great.
This might become what the PAC program is for mental health for dementia.
You know what? That's the goal. I mean, it is so hard. I mean, I've been on so many EMS calls myself where we're trying to take care of someone with dementia who has various issues, and in the ER I've taken care of in over 20 years, a lot of patients with dementia, and it's if we can find a bypass, we can find an alternate solution.
Sounds exciting.
That works.
We'd love to have you come back and fill us in how it's going.
I would love to. I'll let Chief here, defer to you. Even like after the first 4 or 5, I'm happy to come back and at least kind of give a little bit of a qualitative answer about how things are going.
Yeah.
And ask for more money this fall. We'll bring you back.
That sounds exciting.
All right.
Any more questions? No. Otherwise, we thank you very much, Doctor, for coming. We appreciate you taking the time on.
Thank you for your
Thank
support,
you.
and thanks to the organization for participating. I really appreciate it.
Thank you.
We'll move into the chief's report.
Thanks. So you got January's chief report for you, which really doesn't include anything January, but it's the year-end summary from where we ended up with 2019. So if you look at the bottom number, we ended up at 3,443 calls. We were anticipating 3,400, so we were kind of spot on right where we are at, expecting. So that's a 6% growth over where we were for the previous year, which is again where we wanted to be. Another note on there is December actually started off really slow. A lot of those calls actually, for whatever reason, came in the last 2 weeks and pushed us to really high, but that's actually the third month now for 2019, where we hit over 300 calls a month. So it was once in 2019, or it's once in 2018, and it was 3 times now in 2019 where we hit 300 calls.
Is that part, you have 3 ambulances now?
I'd like to think so, except that the 2 times previous in the year, we only had 2. So I do believe some of it is because of that 3rd ambulance. We were just kind of, again, anecdotally, it's a little hard to pull the information on how many times, kind of explained, you know, when other neighboring communities come into our district, there's a lot of things that play into that, some of it being GPS and the closest ambulance. But really, when Jeff and I sat down and thought about it, there wasn't the time in the last at least 3 or 4 months of 2019 where we ran out of resources, such as all 3 of our ambulances were out and our neighbors had to come in and help us out. I mean, they were coming in because they were closer than us. January 1st, we actually lost 2 calls to our neighbors because we actually were out of resources. January 6th, we lost 2 calls to our neighbors because we were out of resources. So
What's out of resources mean?
means all 3 of our ambulances were out
Okay.
on calls already in our district, and we had to have our neighbors come in. And there will never be a day where we will not have to rely on our neighbors, but that's how 2020 is actually already starting out with kind of running down that road.
So Chief, I see our number 1 issue appears to be, at least for the month of December, falls. Have we ever considered reaching out to, for example, the Fitchburg Star and just doing a quick write-up to remind people to like walk like a penguin or something of that nature, just to minimize some of the things that would help them?
We could actually, that's a good idea to start doing some more PSAs. I know Fact TV is always, Jeremy up there is always looking for us to come up and do something for his PSAs. I think we talked about this a couple months ago. Dane County, Falls is actually the #1 EMS call in Dane County. And Dane County Public Health, probably last spring, actually had done some phenomenal, at least charting and saying where are these calls happening at. They're fairly, I'm not calling them fairly isolated. We know where these patients are at. A lot of them are actually at assisted living centers. In case it's a much bigger problem than we can address. But I will actually write down, I like the PSA part of that, to do that. And then maybe that can be, Jeff and I met last week before he's on vacation, so maybe he's watching from his boat somewhere in the Caribbean. But we kind of met last week to figure out what we want to do for 2020, and that would actually be a good project to again partner up with with Dane County and say what can we do as we are trying to do more outreach.
I believe that the Verona Senior Center has some programming around falls too, so that might be another connection.
Yes, so we've actually from Capital, across the street, Capital Physical Therapy, they have been coming with us when we've been doing blood pressures and doing fall assessments with us, at least in Verona. And we started that last year, so they've been sending their physical therapy with us. And we don't see a ton of patients, but that's another program. It's been a great partnership that they've been able to come do that with us.
Patrick, of the town of Verona, last December, we had 13 calls. How many of them are to the Dane County Home out there? You got an idea?
I don't. You should have actually got, and I know that's been a topic out there.
Yeah.
Ask Tom.
Okay.
He actually has all that data from last year and this year.
Okay.
Yeah. You see the other reports there, CAR 15's been out as it usually has. That's the end of the municipalities.
We actually had a couple in our neighborhood.
Out by you?
Mm-hmm.
Yeah.
Not a bad one.
It's not as many as you think.
Good.
Well, it's not as many as we think, because part of that is they will call us when it has to do with nursing homes calling ambulance transports, and there's some Medicare guidelines in there. So if it's not truly an emergency, they will call for a private ambulance service, and we don't know about those calls. So the only thing I see here is emergent calls, and when we go there, they're sick people. Yeah, otherwise, the breakdown is kind of where it's been, plus or minus a couple % for the last many years. The fractal times on there, you can see we're actually sticking pretty good within our normal limits. There was a marked decrease in our 2 things. One of those with our actually response times. Literally the month after Verona Road opened up, It was down by like 90 seconds again, by the mere fact Fitch-Rona Road was open. The other thing we actually noticed was our get out the door time from the time we got that page to actually was going en route, started to actually creep up there our goal is 90 seconds from the time we get notified to be driving out the door. That actually had actually for about 2 months creeped up over that 90 seconds. Digging back in and why that was the case, the new station, all the challenges we faced with Fitchburg Fire Station number 3, the very last thing to ever go in there was actually overhead paging for EMS. I can't explain how the process is, but you either get fire EMS and the building belongs to Fitchburg Fire, so they're the ones who got overhead paging and our pre-alerts. So because there was no digital system in there, we were not getting the pre-alerts that we've been talking about for years, that truly you call 911 and I fell in the city of Fitchburg near here. We get notified that Fitch-Rona Medic 43 has a call here. We don't know what we're going to, just where we're going. That occurs at every other station that when we implemented pre-alert was well documented to save 90 seconds worth of time to get us out the door. That didn't happen for the first 2 months that we occupied that building. December 4th, that was turned on. We actually saw our times go back down to where we were expecting them to be. So some skewed times there you're going to see if you look back in the previous months, just system issues that are kind of rectified now. Now, as soon as Fish Hatchery Road gets closed next year for construction, we're just going to skew all that all over again. But
So far it's been nice.
right? So our times have been looking phenomenal. Yeah. So that they're nothing to worry about other than I report back to our crews. This information does get shared with them about, just being very diligent to even at 2 a.m. I know it takes a little bit to get up, get your shoes on and figure out where you're going, but to really try to keep those calls down, those times down. Up to about almost near 9 calls a day for the average for the year. You'll see our training is on there. Our consortium training is special needs patients. Next week is our department training. Twice a year, we started it last year, we do a training with Dane County. So Carrie Meyer, who's the director, I guess, of Dane County Emergency Management. She'll actually come out to our station next week and we'll do a tabletop mass casualty. And we activate, I think I've shared before, what's called base hospital before. We have multiple patients. The hospitals actually all have a common radio system. So us as unseen and are trying to figure out what we're gonna do with 10 patients. We're not actually calling 5 different hospitals. We call what's called base hospital. We call one hospital. That one hospital coordinates with the other 5. So we know what essentially available rooms or available beds are. So our one person is calling that one hospital and coordinating, saying, I'm gonna send 3 here, 2 here, 2 here, 5 here, and coordinates that. But it can be complicated. So we actually train on that twice a year, starting last year. So this January and June is when Carrie will come out. She'll bring her little Matchbox ambulances and little Lego people, and we'll do a tabletop MCI.
Wow, we don't have much fun at ours.
Yeah, we do it.
Wait till I talk to her.
Yeah, we gotta have fun. We gotta make it happen. Last 2 years ago, I think we were the ones who volunteered. We did it at 5 a.m. Right, to test the night shift, because nobody ever tests the night shift, but bad things happen at night shift. So I actually had 4 or 5 people come in at 5 a.m. and we tested the system. So I proposed 3, we compromised on 5. So yeah, that's actually next week. And then Christy, Lieutenant Schnabel, has been working on getting our training program. That's part of her lieutenant tasks. So that's been kind of a work in progress. So she actually put out some training for us on one of our least commonly used skills, and it's posterior EKGs, kind of some advanced interpretation of EKGs. You see our average calls of the day, hour of the day of the week, calls by municipalities. You see our top one for Falls has been there probably for years. Everything else just kind of moved around. You see cardiac arrest made this list. We again had a record number of cardiac arrests in December. I think we were up to 14. We see an average of about 30 some a year. So we actually had, don't know why. But we actually had quite a few of them
Big
last.
snowstorm? No.
No, nothing. Well, the weather was nice, so that's probably what it was. People were outside actually doing stuff. So that actually made our top 10 list, top 10 calls for the last month. Something I started reporting a couple months ago is who's getting all the calls, and it's still station number 2, which is kind of right in the middle of the district, as you'd think, is actually turning into the busiest station. And that northeast station, I don't want to call it the sleeper station, but it's turning into being one of the slower stations. Still dealing with some geography challenges of if City Med 6 is in Quarters, they are 6 seconds closer to anything down the Highway 14 corridor, so they're driving right by our station. But it's what the computer pops up with. Similar, there's a little spot on Greenway Cross. If Town 66 is in Quarters, they are about 12 seconds closer than we are from that station. So without getting in and like making the speed limit on South Sain like 150 miles an hour, they're always gonna be closer than us. So kind of
Well,
still.
they won't be there much longer anyway.
Yeah, not going to be an issue in about a year and a half. So we're kind of playing with that. Otherwise, things are actually going with that new station. They're going very well. Crews are liking it. If you flip it over, you'll see our financial report for December. That's where we're at the end of the year. Everything is kind of where it needs to be. I fixed the math. Greg's not here this month. Fixed the math on my spreadsheet. Figured out what it was. Right, it just wasn't adding that last line in there. The WISC funds. Previously, the CDs were in there twice, so it had to do some weird math. But now it's actually all correct. Just a reminder, if you had looked at from the previous month to where we ended up this month, that because we moved that checking account, all those funds are to the checking account now, that checking account maintains the higher balance to be insured. That's why you see previous month that checking account was 273,000, and last year was 263, and the end of last month it was down to 154. So that's why those funds are in a different spot. Otherwise, everything else is right where it should be. We would expect. We didn't move any. The FAP funds we did. So the FAP funds, that's the funding assistance program. That's the money we get from the state. X amount of dollars of that has to go towards training. The other half, it says what I can use it on, but a lot of that is equipment as well. Traditionally, in the past, I've actually helped the fire departments with that because they're first responder programs. First responder programs don't get state assistance. They keep asking for it. It's only transporting agencies. So last year we did the same thing. We gave $1,000 to Fitchburg to help them increase the fire department to replace some of their first responder bags that ultimately help us. Same thing we help with. Fitch-Rona is buying some equipment. We'll give some of that money to them. It's money we get from the state. So that's why you see that change in the FAP funds there. Otherwise, the WISC, that's that sick time accrual. That's the finances. I will segue quickly then to the in-house budget, which should have been that next sheet for you. So this is kind of the unofficial year-end, what QuickBooks says we did for the year financially, knowing that there's still probably a couple of those like end of the quarter fuel reports and bills that are still going to come in from 2019 that are going to get paid on here. But run income was down about $182,000. I think I mentioned that last month. So Michelle and I are going to look at kind of the breakdown of, just off the top of my head, I think we're getting turned around on a lot more calls. That has to do with that auto ALS of being sent out to other communities and them getting there and saying, we don't need a medic. It sounded bad at first. We don't need it. So we're going to make sure that our formula is correct when we figure in the no transports. I can put up, I can say we're going to go to 5,000 calls, but we get turned around on 2,000 of them. We don't bill for those. So we're going to look at that and make sure that our run income is being predicted better for future.
Chief,
Yes.
do I understand correctly that we had a little bit of a variance on the run income, correct?
Correct.
And so we're slightly below where we were targeting?
Yes.
Okay, got it, thanks.
Yep, anything parentheses is under, anything not in parentheses was over. Separated out the contracted events and external supplies. That came at a suggestion of Misty up in Fitchburg, and you'll actually see that much clearer on the now when I start reporting this in 2020. We have kind of this fund where we pass things through when we purchase of Fitchburg Police just purchased another AED, so they'll get that through us because we can get state pricing for it. We don't charge them any. I mean, I buy it, they pay us back, and we're good. So we just move those funds through here. But unfortunately, it comes in at this miscellaneous line item, but at the bottom, it actually comes out as a medical expense. So it actually looks like we're overspending budgeted line items for money that we're not actually spending. So starting 2020, we actually did separate those out kind of as an external vendor and an external income and external expense to truly get a better management of what we are doing. If you look down below, We were actually under in wages across the board. Great. I think I'm gonna accommodate that to, or attribute that to, I think we got a really good LTE pool when we did this last hiring, and the LTEs were actually able to pick up a lot of the overtime that we had, so we didn't have to pay overtime to our crews. Yeah, so unfortunately, that was not under as much as run income was also under, but it worked out pretty good there. We were a little bit over in health insurance. Other big stuff to pick out there, we were actually over in medical supplies by quite a bit. One of those is the price of pharmaceuticals is just completely unpredictable. I can be paying $50 for a vial of epinephrine one month and $150 the next month. It's hard to predict. Other component is I did invested essentially in 2 upgrades or improvements to our supply system with the 3rd station this last month. We're using the same supply system we've been using for, I believe it's about 6-7 years now, in 2 steps. One, to save the time of our lieutenants who essentially manage the supplies at the stations, and they're doing inventories. We actually switched over to, or upgraded to an RFID tagging system. So all of our supplies are actually now tagged with a radio frequency tag, and instead of them going in somewhere between half an hour and 4 hours and counting everything in the room, they're actually going in there with a scanner, and standing in the middle of the room for 10 minutes as it's beeping and beeping and beeping. All that gets dumped into the computer, and then they go and order based on that. Just do a couple of little audits to make sure it's accurate. Second thing we upgraded, and we just implemented that this week, was our controlled substances. Previously, everything was on paper. So we had a couple different logbooks in the ambulance, one in the vault, and then I reconciled it based on a report that may or may not be accurate when it came to me. And then if the counts were off, I was going back and spending hours of my life every month trying to figure out where this stuff was tied to. We don't have a problem, so which is great. We've never had a problem, which is great. But now actually all of our narcotics and all of our controlled substances are actually individually tagged with numbers. And I said it just got rolled out this week. So it's been a steep learning curve for some of our technologically challenged people. Yes.
I'm wondering how you would get rid of this, there it is.
Yep, yeah, so that was it. So now all of those drugs are actually individually tagged and tracked by number, by vial, and the crews track those. So we were over in the medical supplies line item. I think in the long run, that's gonna save us the opportunity costs for both the lieutenants and myself. Most of the other stuff we were fairly under down there. The radio equipment line was a little bit over, and that was because we purchased those radios this year. And with the new ambulance this year, those new radios were not budgeted in the price of that new ambulance. They were with the old radios, which are significantly they had cost less. So to get the new radios with the new ambulance, we went over. All the other stuff you look at there, the bottom line, so unofficially was $3,800 over budget. Again, there's some stuff that's not come in yet, so we'll be looking for a handful more bills to come in that I'm not anticipating any of them being significant. Other note to come up with run income is, though we anticipated that increase in run income the last 3-4 months of the year with that new ambulance, those don't get billed, and they get billed within a couple hours, but that's not usually collected, not hours, couple of days, but that's not usually collected for 30 to 60 days out. So anything we saw in November, even those high run numbers we got in December, we're not gonna see that income until the end of January, February. So unofficially, that's a snapshot of where we're at.
So my point, again, for anybody that happens to be watching this is, it's pretty impressive when you take a look at a budget that's $2.5 million, and we are within 1.5, we're within 0.1% of that budget. Nice job. I know that's not the primary point of what we do here, clearly, but when it's that tight,
Yeah.
well done.
Thank you.
Especially in the transition year.
Yeah, I said, Brian set me up to succeed, so this one was mine to fail, so I think I did okay.
I meant transition, new station. And all.
Oh, yeah, that was, me as well, yeah. The new station as well, yeah, caused
The unknowns about that.
Yeah, as you see,
Yeah,
we
good
went
job.
over a little bit in that new station. Our external, this year, when we have the auditors come in, so last year was the big audit, and then I think, you know, what we call the other 2 years, the little audit is, I guess, what we call it. They will be here on the 4th
4th of February.
of February, so end of probably Marchish, Aprilish, we'll get the official report from the auditors on where we sat for the year. Something to keep in mind with that as we look at future budgets. We were sitting good, really good last year had that budget, I don't want to call it a budget excess, but we were over our 20% reserve last year, and that's that funds we put into that sick time, which really helped fund that sick time. But that was 20% of a $2.5 million budget with 14 medics. That budget went up over $500,000 this next year. We are not at a 20% reserve anymore, just because of the mere fact that our budget went up that much more. So something to look at within, my thought would be in the next couple of years, is we may need to start kind of putting a line item in there to help put that reserve back up to where it probably should be. But we'll see what the auditors have to say. Last two things in the chief report there is the milestones. This is my 19th year here.
Congratulations.
Forever. And then Kyle and David hit 15 years. So we have I'm gonna call it, I'm gonna say it, a positively constructive aging workforce here, as in time here, the experienced workforce. How's that? And then Pat Marsh from the city of Fitchburg actually asked me about the bottom line there at our department head on Tuesday for comparables, when I said we were up 6%, and was, I don't want to be proud of that we're busy, because if we're busy, that means bad things are happening, right, to other people. So we're up 6%. So just to look at actually where the communities that are our size are as well. Sun Prairie is truly our closest comparable. They are, you can see by the call volume there, population served. They're, I don't believe, square mileage quite as big as us, but as far as a district-wise, they're, I believe, about 5,000-6,000 less than us as far as a district. The city of Sun Prairie is larger than Fitchburg, but our 3 communities are larger than their communities.
Is that because the city of Fitchburg encompasses the entire land mass? And in Sun Prairie, they would have the city of Fitchburg in the town, or the city of Sun Prairie and the town of Sun Prairie?
So they also serve a couple of the townships around there.
Bristol, I think, is one.
Yeah, they have some of the townships as well. So yeah, geographically, we're bigger. Population-wise, we are bigger. Yes. But you'll see that Middleton, I bring Middleton up there because they are also the only other two ambulance system comparable to us, though you can see their volume is less than us in Sun Prairie. But those are the percent changes between 2018 and 2019 as well. So everybody was up. Sun Prairie was significantly up, that 11%. They also, if you recall, implemented a part-time third ambulance last year as well. And I think they did that actually towards the beginning of the year, so it was out there earlier. Essentially, they still run out of 2 stations as well. They just consistently have an opening for part-timers out there. If 2 part-timers sign up, they put that third truck in service. If 2 part-timers don't sign up, they don't put that truck in service. And that's how they're staffing that for a while. The bump over 3,000 calls for them in 2019 is, I think, going to help feed probably moving that to a full-time truck here in the fairly near future. So that's what I got for a chief's report.
Okay, thank you. See, chair's report, I don't think either committee met.
Neither one met.
So let's move on to the sick leave policy.
So this is the same sick leave policy you saw last month. The Local 311 had their 21-day input period. 2 things that they brought back that I felt we should probably just bring back to this committee. And it's truly under there. I'm sorry, they didn't print whatever color I printed. They're peach. Apparently, bad color to pick. Under the employee eligibility requirements, is the employee terminates, they wanted all full-time Fitch-Rona employees. It really, they're looking at, as we talk about LTEs and part-timers, they wanted that full-time in there because they wanted that option to come back. That really kind of piggybacks, I want to say, on the one that was at the bottom there, but Fitch-Rona doesn't dictate what the retirement qualifications are. That comes from WRS. So that's why I put the bottom in there, the little parentheses that says, you know, that we don't have to bring this policy back to the table every time WRS, the Wisconsin Retirement System, every time they make a policy change, we don't have to come back and change our policy. They are the ones that determines what a retirement eligibility is. It is currently, when they leave here as a full-timer, they cannot transition from a full-timer to a part-timer, or even a full-timer to an LT. They actually truly have to quit Fitch-Rona and reapply for a job here after it was 75 days, I believe, is what the current time frame is. So, I mean, they can put full-time in there. It truly is. They have to quit. They have to retire from Fitch-Rona. If I want them back, then they can reapply. But those are the only two requirements, those are the only two suggestions they had. I felt it was worth bringing back to this group to say you were okay with that.
A question, you have and or on that last one, is that,
I had and in there, they wanted or in there. To me, it doesn't make a difference because WRS dictates the requirements.
so it is or?
It would be, it'll be changed to or.
Or, okay.
Yeah. There's two things. One of them, age drives it, and years of service drive it. And everybody shoots for this 20 years when really you only need 5 years. But there's some age requirements that go along with it. Everything else is what you looked at last month. So I don't even know that we need action on it. You approved it last month pending their comments. If you're okay with those comments, I think we can be fine with it.
Yeah, I had one question, and I think you answered it about
Yeah.
the funds being distributed, and it's part of a contract, I guess.
Yes,
Yeah.
you brought that up. Yeah, once those funds go up, and I actually did, so Mr. Dodd from the whatever the name of the firm is out of Janesville, he actually came up and enrolled our 4 employees. And I did double check some of the questions we had last month, and one of those was the beneficiary. And how he explained it to me is it is an IRS rule that should, and clarified it even more, a employee's dependent, at least for the purposes of an HRA, as a spouse or a dependent child. So if you are, I bring up Ross, who is unmarried with no children, who Ross actually opened up his account this year. If something happens to Ross, his funds don't come back to Fitch-Rona. They actually are dispersed against 2 other program members. That's how he explained it to me, is that is how the program is run. It would be similar to Dale, who paid into the program. As long as he has a surviving spouse, it goes to her. Now, if Dale's spouse passes away before him, though he has children, they are not dependent children. So that money actually goes back into the program. So I think.
So it's a little different than it used to be, but.
Yeah, so I think the employees are all targeting each other now is what they're trying to do.
Certain employees. the ones
Yeah.
that are-
Yes, there's yeah.
So it doesn't go to their heirs, so what you're
It is,
basically saying.
he said it is.
Only if they're insured. If they're covered by insurance, I think what you said, family members can use that money. So if your spouse or kids are under your insurance policy when you die,
No,
no?
No.
That's how the state is,
no, it only is spouse and a dependent, so that money is gone.
if you're a dependent child, yeah.
If you're a dependent child, so,
Yeah.
yeah,
Yeah, that's what I meant, yeah.
yeah, or 26, yeah, if you claim them as a dependent is what
Yeah.
he said.
It's a little different, but,
Yeah.
okay, so we don't need a vote on that one?
I don't think so.
Okay,
We voted on it last month, if you're
Okay.
okay with the changes.
thank you for the update.
Yeah.
No. And then we need to set up a committee.
There's one more, the other policy, the
Can I skip
procurement,
one?
administration.
Oh, yeah, the drugs.
Storage and disposal of medication. This exists, I mean, it's truly operational, but it exists as a policy because it has to exist as a policy. It's part of our operational plan we submit to the state. Because I changed how we manage controlled substances, I had to change the policy to reflect how we manage controlled substances. And I changed it, I tried to make it more generic enough. I do have an operating procedure in place, so we have an SOG in place on how we do this. So I tried to make the language in here fairly generic of go follow the policies of how we do this, because it's only been truly in place for about a week. So I'm coming up to finding maybe some hiccups in there that I might have to go back and explain it.
Would that last paragraph on page 3 fit better under 1 than 2? I mean, the first one where they're talking about name and address fits, but the other one actually is the process you're using now that replaced this process, correct? The under completion of the call. There's an additional signature page in the PCR for the use of controlled substances.
So tell me again what paragraph you're looking at.
Because here it's telling you that interns and students may not verify counts.
Correct.
There's nothing before that that says, it has this information about needing 2 paramedics. I was just wondering if you would put that last paragraph above storage, where you crossed out the paragraph under upon completion of the call.
We could.
Or move the interns and students may not verify counts to that paragraph.
Yeah, and I really could probably get rid of that whole paragraph. It just needs to be noted in there somewhere that they can't, and I could probably get rid of interns and students may not verify counts because it's all electronic now, they can't. Because they don't have access. It's all a password and PIN system, so they can't even be entered in there as an option to do that. So I really could just get rid of that whole, some sentence has to be in there about go reference the approved SOP. I can edit that and take a look back at it. On the front there, I also crossed out, so our new protocols, every 2 years we visit protocols so our 2020, 2022 protocols, I think February, it's not gonna happen in February, probably March or April, those will be implemented. Morphine is actually coming off of we're not gonna be carrying morphine anymore, so I just took morphine out of the policy here. Same thing with diazepam. The only reason we even had diazepam in there, they were part of our weapons of mass destruction kits. They were part of a nerve agent exposure. They haven't made those in years. The ones we actually had kits on our trucks that had been extended by the FDA for years. The last expiration finally ran out. We can't even get them. So I just took it off there because we don't even carry it anymore.
Morphine's not part of chest pain portfolio?
Not.
How often do you do fentanyl? It's pretty strong stuff.
It's like, I don't want to say publicly say like candy, but it's like candy.
Really?
It's the
Wow.
go-to pain med. Fentanyl
Pretty
and
potent stuff, but.
so yeah. So I mean, I will share that the number one medication we give is fentanyl and nausea medication for the fentanyl.
Yeah.
The new protocols actually do contain Tylenol and ibuprofen. For what it's worth, but there is a nationwide movement towards trying to reduce narcotic pain management. Yeah, it makes sense to the movement. We'll kind of see how it pans out. A lot of it is just the nature of what we do, because we get called usually for pretty significant things.
Yeah.
Like, here's your broken leg and here's some Tylenol. I mean that's an extreme case, but there is now Tylenol and ibuprofen and Toradol. So which is essentially liquid ibuprofen. So there are 3 now new non-narcotic pain management tools we will have starting March-ish.
These are IV.
Yes, yeah.
Are they more potent, so they have a little punch to them?
Toradol is a pretty good pain management drug. The other stuff is truly, it's Tylenol.
The Toradol helps make the other medicines work longer.
Okay.
So it's not a controlled substance, so it doesn't have to be part of this policy, but, so we just need to, because it's a policy, it's got to come back to this group to look at.
So do we need
Yeah.
approval?
I think so.
Make a motion to approve?
I just have one more question.
Oh, yeah, okay.
So when you do your monthly check for expirations,
Yes.
do you allow them to expire, or if you are doing your check and they're gonna expire within a week of when you're rechecking, do you pull them? Or,
Well, that's part of the new process we haven't quite figured out yet. So
or you're
normally, yeah, so
identifying,
yeah, normally they were allowed to expire. You know, somebody put a sticky on it or post-it note said that the morphine in here expires next week because it, depending on what brand or what vial it is, they'll either expire on the 30th or rarely we get the one that on the 14th, right? Most of the time it's at the end of a month. Every once in a while there's a date. So normally we would allow them to expire. Because this new system is digital, it actually turns yellow and red as things expire. My thought is because now I can see daily and I get those reports of when things expire, it'll probably be the week that it expires. We'll go through and change it out because of the tracking style of things. Now it's in our SOP for the crew to actually go through and pull it, but because it is truly, I mean, before they signed it, said here it goes, and they gave it to me, and then Jeff and I did the paperwork and did it. But now it's the complications of they have to unsign it and unseal it and take it and turn it in and do, there's a lot more steps involved before it gets to me so that I can throw it in a box and get rid of it. I think we're gonna come up to a kind of a near time thing and pull it before. Most of all these controlled substances are actually really cheap.
An example, the drug expired yesterday.
Mhm.
And it's in the ambulance, I'm just using it. But I needed it. That's the one they're gonna give me in the ambulance.
It should come off the truck.
It should, you can't give it to
I
me
can't give you expired drugs.
if it's expired one day.
Nope.
Okay.
But technically they work.
Yeah.
Yes, but if it doesn't, then it's expired.
Then you get
Then
sued.
bad things happen.
Yeah, that's,
The ambulance
Yes,
chases
you
are
can keep your
lining up around
yogurt
the
past the
corner.
date.
I know, you
Your
can
milk,
keep it a week
milk
and
is
it's
good for
fine.
2 weeks. Fentanyl's probably good for 100 years. But no, once it's expired, we have to get rid of it.
that's all I got.
This isn't
Sorry,
like
that's
making
close
blizzard.
enough.
Any other questions? Otherwise, the motion to approve?
Motion to approve.
Second?
Second.
All in favor?
All right.
Any opposed? The procurement, administrative, storage, and disposal of medications control substance policy is approved.
Perfect.
Isn't it?
I'll send it out. They'll have 21 days, but
Then on to setting up a committee for negotiating part-time employment.
yeah. So we talked about this last month. Kyle, as the union, came back. Their recommendation, their request was that they don't want to touch the contract, right? What we can do though, as far as moving forward with something like this is create a memorandum of understanding and that's how we fix things. If there's like a date that works better, we'll do an MOU. It's still binding like a contract, like their collective bargaining agreement. But the plus side, and we talked about this, the plus side of not opening, if we truly make this part of the contract, we have to come to an agreement or we proceed to the mediation arbitration policy. By creating an MOU, if we don't come to an agreement, either one of us walks away.
Yep.
So this is actually a better way to proceed. But I would still like to move forward with it. I've talked with Kyle, I've talked with a number of crew members, and I think it's out there as far as the spirit of what I'm looking for this. But because it's an MOU and technically we are bargaining, I would like to create a bargaining unit. So the people who were on the committee last time were the elected officials and JR. So I will put it out to you as, I don't think this is going to be a huge time-consuming commitment for it. My thought would be, we have to meet at least once. I will put a proposal together. We will meet and talk about what that looks like as far as wages and benefits. We'll meet once with them, probably do an exchange, probably meet once after that. So my guess would be 2 to 3 meetings. There's no tight timeline for this. This is a convenience thing.
Okay. Is you all okay with serving on that? Yeah, okay. Well, we'll proceed that way then.
Proceed
The
as,
only consideration I have is we have elections coming up in April. So we've got that window probably to work with.
okay.
Well, I'm not opposed, so.
Yeah. So we'll move forward with the elected officials at this point, and then if we need to do some midstream adjustments, we'll find representative, or JR can represent however you want to deal with it. So we'll put the four of you on the committee. I will work on probably sending out a doodle calendar or something like that to find out when a good date is in the next few weeks.
And I assume we've done this before, so it's not like I need to loop in HR from the city for this.
Nope, I will absolutely share it with, I did the same thing when we had the collective bargaining agreement. I shared it with the city administrators. I don't know that I shared it with HR. I did share it with the city administrators last time. So before we come to any finalization of it, we'll absolutely share it with the municipals as a whole if they want to see it. Yeah. So, okay.
Okay, you want to talk about the
Sure.
possible internship
A
program?
lot on the agenda this month, I'm sorry, this probably
Yeah.
could have waited. So I gave you a document to look at. It's just, I pared it down to, I think Kyle's watching from up in Fitchburg, so I'll give Kyle credit for putting, I reduced it down. As you said, he's got the works cited in the back, so I did pare it down to the PhD dissertation that you put together for me. It's good, it's some good content in there for a background and a proposal, but essentially what we looked at, we've been talking about this for a while. Fitch-Rona has always had an internship program that we partnered with our fire departments with. It's been highly successful, as he mentions in here. All of our interns who have ever graduated from here have moved on to full-time positions with fire and EMS in fire and EMS world. Last year, and most likely again this year, I think just kind of due to the nature of the changing world of internships and programs that are out there, we did not sponsor any interns last year. And as far as I can see, probably this fall, we will not be sponsoring any interns this fall. It is not a requirement of the fire internship program. They do their fire internship in their second year of their fire internship if they are interested in EMS, which if they want a fire job, they should be, but most of them don't understand it at that point. They get involved with us in that second year. They start riding with us. If we see potential, they express interest. We interview them, we apply, and we sponsor them through their paramedic program. That interest, either the students weren't there, the interns weren't there, or there was not an interest, and it's not for everybody. So what we talked about ourselves is I've been approached a handful of times every year for years from external people who are truly only interested in an EMS internship. They don't want the fire side of things, right? They just want to be a paramedic. We don't have a system in place to manage that right now. So what we looked at, and Kyle again put this together with a lot of research and supporting documentations, is why don't we create a Fitch-Rona internship ourselves, essentially an EMS internship to kind of work in parallel with that. This is a really, let's call it about a 1,000-foot view of what we want to do. We've worked a lot of specifics out. I think until we actually do this is when we got to figure out what the other parts entail. Essentially what it would be, we would put out an application process that, we're looking for an internship. We also don't want to box these people into this is what our internship is. As a fire intern, it's pretty clear how this process works. For having somebody come in from the outside, we could get an EMT basic who's been running for 10 years. Their kids just got out of the house and now they have time to go to paramedic school and they're looking for an internship. We could have an 18-year-old straight out of school who's like, I don't want to be a firefighter, I want to be an EMT, or I want to be a paramedic. So somewhere between the paramedic program, whether we go through UW or MATC, is about a full year. And what we currently do with our interns who come from the fire service, they express interest early in the year. April or May, we interview them, and about June-ish, we actually partner them up with a mentor. So they're actually signed one person who's a point of contact at the service. They're matched up then on that person's shift. So if that person trades, they don't follow them, they don't move around, but they work the same shift schedule that person works with their Kelly, but they're always here 2 days a week.
What is it, Kelly?
Yeah,
So
Kelly Day,
the Kelly shift.
or Kelly shift.
So because they work 24 hours on and 48 hours off. So they always work 2 days a week. Well, every 3 weeks, that would put them on a Sunday, Wednesday, Saturday. They can't work that many hours in a week. That's a 48-hour week. So every 3 weeks, they're off either a Wednesday or the Sunday. So they work 2 days, 2 days, 2 days, but then they have off the Wednesday, then 2 days, 2 days, 2 days, they have off the Sunday. So we actually have people here who only work every Sunday and every Wednesday. And then everybody else moves around those days. So that we call that our Kelly shift. Is that?
After or something?
Yeah,
I have no idea where it came from.
Just shake your head. at this
Kelly
stuff.
shift.
Yeah, it's the Kelly rotation.
Okay.
Essentially, it's their day off, even though it's not really a day off. It just, otherwise they'd be working a 72-hour week, and they can't do that. It's a 48-hour week.
Oh, God.
So, yeah. So anyways, it follows there, but they have that point of contact, and what we would do this would increase as well, kind of define the responsibilities of what that mentor is, because right now it's pretty hit or miss. You get mentored with Kyle, Kyle's going to make you work, he's going to you're going to write him a paper, you're going to do a presentation, you're going to organize a training. You partner with somebody else who's just going to make sure you pass your tests. So this would define actually what that internship is. Now, once they still have to get into the school. I mean, they're not automatically granted. They got to apply to the programs. Once that classroom starts in the fall, they stay on that 24/48 schedule. But when they're in school, they're not here. They're just off. And then that night shift, though, they're expected to come here. They can put in for vacation, families. We work with them on their schedule. But the intent is while they're here, right, they're applying what they've learned in school. They're getting their experiences. They're getting 48 hours a week of street time with a very experienced paramedic crew. So they're doing that the entire way through their paramedic program until they graduate. So that's our current internship program with fire.
Grow your own.
Absolutely. So what we're looking at here is an opportunity for us to say we can bring somebody on board. Now, whether they have an EMT, brand new EMT, they haven't run as an EMT. One of the options here is if we wanted to do a whole 2-year program, we aren't going to put anybody through EMT school. They need to apply with an EMT. Based on that experience, we would consider whether sending them to the advanced program, which is a 1-semester program. So they would be riding, they're getting there, if they come with no experience, I mean, to be a successful medic, you can go straight into paramedic school without being an EMT. There's no requirement that says you have to do time. Being myself and the number of educators who work here, is a lot easier for somebody who's got experience and knows what you're talking about, right? You've actually seen a diabetic patient before you start talking about diabetic patient treatment. So if we would bring them in that semester, we can send them to that advanced EMT course, 2 nights a week for a semester. FAP funding would actually help pay for that. Then we can put them in paramedic school in the fall. If they come with lots of experience, we can put them in that internship and send them to paramedic school in the fall. So there's an application process. They would come here, essential basic knowledge of EMT, basic practical skill, written skills and practical skills, interview process, looking at no more than bringing 2 people on board, because right now that is what our funding is. We can look at that process in the future, but it's been in the budget to pay for half of the tuition for 2 people. So the other part of this, as far as compensation goes, is I don't know the success of the program, and this is why we just kind of do it and see what happens, is currently this is an unpaid internship. When we get the fire interns, fire internship is I don't want to call it a paid program, but they are paid a stipend. Right? They're given housing, and they're given a food stipend. So this would be different from that. Those interns wouldn't live here, so currently it would be unpaid. We'd be expecting 48 hours of volunteers work out of them and not pay them. But in exchange for that, we're paying half of their tuition, so roughly $3,000 towards their tuition, plus uniforms, books, and lab fees. So it turns into about $4,000. We give, we don't give to them. We pay it to the school and we reimburse them for their supplies. But in turn for that, we're giving them the opportunity, right, to work with us and ride with us and get an education. Mm-hmm. Part of the end part of it then is actually giving them an LTE position upon graduation. We like to say, they may be offered a job, right? If it turns out this was just a struggle for a year and a half and they've made everybody angry, like I'm not going to hire them. But to give them, if it was a phenomenal student, it's an LTE position to potentially bring them on as a part-timer or a full-timer. That's what we're looking at as far as a program. And I don't even know what I wanted to bring it out to this body to see what your questions are.
That's great.
Yeah, sounds good.
in the
Have you seen
future,
any other communities try this and what their packages have looked like to get a sense of, is it competitive? Has it been successful?
I am not aware of any other EMS agencies that do this. Fire internships are common. What we do with the two fire departments, fire internship to a paramedic program, is common. They tend to run them a little bit differently. Like the town of Madison brings on those interns. They send them to paramedic school their very first year, and then they use them as paramedics to staff their ambulance while they're going to fire class. Right, it's a cost savings on their part. They can staff an ambulance. That's not our intent here. I don't know of any other EMS-only internships in our area. Eventually, like I said, I'd like to roll it out. I'd like to put a couple people through and see how it works, see what we get for applications, see how it truly works. When we first even started looking at this is how do we, a few years ago when we started talking, how do we reach those how do we diversify our population, right? We have a huge diversity of population in our district. How do we reach out to them and provide them with this opportunity, right? They don't want to be firefighters, but they just want to run EMS. So hopefully to targeting some of that. We haven't figured out how to roll that out yet. I've actually talked with Greg Bailey, one of our medics, is actually now the program director up at MATC. He took a new position up there as well. So we kind of have an in at the college, right, to help us kind of roll this out and see who we can get in this population here. Eventually, right, as I bring it to you, it's not an ulterior motive, but eventually I think this needs to be a paid internship. Now what that pay is that a stipend or is that minimum wage? I don't know, because it comes with a cost. So I'd really like to get it up and going and see how successful we can be for free. And then,
Well, it's built in the budget.
so the tuition, cost of school is built in the budget because we were doing it for fire. The cost to pay them to be here for 2 years at 48 hours a week is not. So it's unpaid.
$40 a week is not.
40 hours.
40
hours. And I did reach out about what volume, it's always been a question about, what is can you volunteer? Can you do a stipend? Because we still have Tom Bates, who is truly volunteer, right? We pay Tom Bates nothing. He comes every Sunday afternoon and hangs out and goes on calls, which is good for him. But if I've got, 2 kids that I finally got off in school and I've got some time, but now I see this opportunity is I want to go be a paramedic. METC offers a night program, a paramedic. It's 2 nights a week and every other Saturday, which is also actually distance learning. So they're making their program a lot more accessible to people. So people can do that from home, but back to the, I don't, if I got to work, because I have a family at home, I can't do this for free. So we can, though it's not going to be a lot, it would be something.
Is Greg teaching at METC and not here anymore to be quick?
He's doing both. He's one of my Cali people. So he works every Sunday, Wednesday. So he's here every Wednesday and he teaches the other 4 days.
Okay.
So in the internship space, do we have an opportunity to go and talk to like one of his classes just to introduce who we are and what we do and,
We can.
and potentially use that as a mechanism to draw people in?
We can.
Okay.
Yeah. So I think there's a huge opportunity here. We've been talking about it for years. I think it's finally just like, let's do this. Because it to me, at least in Patrick's brain, it has always come down to, we're asking people to give me 48 hours of work for free. We're asking them to be volunteers. And we don't want to go back to the volunteer days, but I think this is a great educational opportunity. But I know that, we've asked for a lot from our municipalities for funding for the last couple of years. And if it comes down to cutting something, that I need to pay my staff and I need to put supplies in the truck. So this is a back burner to me. This is an easy thing to cut. So we're gonna try, see what we can do for free, and then probably 2021, 2022, come back and say this is what it will cost.
Put it in the budget?
Yeah.
Okay.
Well, and it also just seems to me that if part of what we need to do is recruit, we're either going to be taking from another organization or we need to find people that want this as a career path, right? And so if we find people that we bring in from a career path perspective, there's an opportunity to help shape that to be consistent with what we want to see as an organization instead of how another community did things.
Yep.
That's a good point.
And then it does beg the question of, rough math, was, I think even it was like $10 an hour for 48 hours a week. It's roughly $30,000. My math is probably way off, but 25,000, 30, that's a good chunk of money for somebody that, once they're done with this internship program, I trained somebody to go work somewhere else. Because if I don't have an opening, I can't hire them, right? I brought
You
up.
have 2 years experience before you get here anyways.
But now I've got somebody with 2 years of, right, I've watched somebody, we've molded them to the Fitch-Rona way, whatever that is. So that is always a question as well. Are we truly spending the taxpayer dollars for what is the outcome for us? I got a well-trained paramedic, and I've hopefully increased the diversity of our field, and we've put a good provider out there for potentially somebody else to use. Yeah. So keep that in mind.
I think there's the flip side. Our staff also benefits from this.
Yeah,
Ken,
yes.
and I mean,
If they work.
Yes,
Work out.
yes. And so, I will absolutely put it out there. If this works and this is successful, I would not be surprised in 2024 when that new contract comes, that there's mentorship pay or request for a stipend.
yeah,
Ask about
Yeah.
yeah.
So,
Which isn't,
responsibility and add work.
yeah, that happens in other fields.
yes, and I'm okay with it
Yeah,
as long as I have something that I'm holding them accountable to do.
yeah.
Right, here is your extra pay, but you gotta work for it. I said, I'm okay with that, and we briefly talked about this last time, and I said, it's coming, but you gotta work. So, that will come. I know it will come, but if we can get a program in place, I'm gonna work.
Yep.
So, I wanted to share that with you, I guess, and kind of get an unofficial,
That sounds like
Drive on.
everybody is pretty supportive.
okay? Thank you. My next step is to put a group together from our staff who is, I think, interested in kind of developing what these guidelines are, and I'll just keep you informed on what happens.
Okay, thank you. Everybody get a chance to look at the accounts payable checks?
The only question I had is it looked like there was a weekly charitable $30.
That comes, it goes to the employees can give a donation to the union. So that actually, the employees, they make that donation. We pay the check, but it comes out of their paycheck.
Yep.
It goes to the IAFF charities
I don't remember seeing that before.
every 2 weeks.
Yeah. Any other questions? A motion to approve?
I make a motion to approve the bills. I'll second.
Second, all in favor?
Right?
Aye. And no opposed, motion, payable checks are approved. And review Gatsby 54.
Sure, so that's the usual, let's be the first one of the year. This is our assigned funds and how those change. So we talked about those a little bit at the chief's report. The first two lines you'll see on there, that non-spendable inventory and non-spendable prepaid expenses, those will change after the auditors come and tell me what those numbers are. The rest of those numbers are what we talked about. We have 7,000 in FAP, 231,000 in sick leave, 24,000 for contract fees. That 24,000, I don't know that I'll tap into it. I gave Leslie, our attorney, or the heads up on our MOU. So I'll bring her in for at least one of those meetings. As far as essentially it's contract negotiation, so I'll bring her in for one of those. We do have a line item for legal fees. So I'll tap into that first. If we end up going over that line, we can pull from contract negotiation funds, but we'll use that first. And then the Epic bike team, still have $1,000 sitting in there. I'm hoping to replace some high dollar items this year for that, so we may actually use that up. And then the $9,000, that's the purchase of the sale of the ambulance from 2 years ago that got stuck in a 2-year CD that will come due, I think, in July. We will cash that in and put that into our reserve to help pay for the one we just bought.
Okay, so a motion to approve?
I shall move to approve.
Second. All in favor?
Aye.
The 54 changes are approved. And then other business,
Yes,
Mike?
we're still having our equipment entanglement class on March 14th at Cross Plains Fire Department, Dane County Farm Bureau. The class had State Line Farm Rescue. They charge $165 a head per person. Dane County Farm Bureau is picking up $115 of the cost for the first 30 people that sign up. I'm up to 9 so far. No, take that, 4, I haven't got the check for them. Another 5 said they're coming, but I haven't received the check yet, so it's 14. So I'm trying to get more people to show up. Normally, Andrew Jensen doesn't miss one of these things, and he has, I don't know if he doesn't know about it or not, but he normally shows up, but I haven't seen hide nor hair of him.
What's the focus again, this year, Mike?
Equipment entanglement.
Entanglement, okay.
I have got a 4-row corn head coming in, and if things go well, I can get the power unit to run it, so we can take the dummies and stick them in there and just run them in, and then let them try to get them out. So, it is a very good class. Deputy Chief Jeff Doslick took it 4 years ago and learned a lot, he said. They got to see what some of the farm equipment is that he had absolutely no idea was.
And he hurt himself, so we're not allowing him back out there.
So what's the cost for the first 30 then? I think they-
$50.
So I still have not seen that yet out on the distribution. Did that go to Dane County Fire Chiefs yet?
Several times now. It just went out last week from Oregon.
Okay,
Because I have
that's
had,
probably why.
I lost Chief Givers, who sent it out, and then I can't get Michelle to call me back. She might be busy or doesn't want to call me back, I don't know which, but, so I went to somebody else. And part of it was, I was too busy in November and December to even worry about it. I wasn't even making town board meetings. But
Mike, any other? If not, next meeting is February 20th here. Motion to adjourn would be.
so moved.
Second.
Second.
All in favor of adjourning?
Aye.
Meeting is ended.